Good morning. Good morning, colleagues, and good morning, ladies and gentlemen. It's a great pleasure for me to start this presentation. And in doing so, I'm going to bring you all back from that wonderful place we've been, looking at thriving, to surviving. We're going to be back to surviving. And in the Limpopo, we tend to have to survive quite a lot. In presenting this 24-hour review, or 24-hour death reporting, I'd like to acknowledge that the role played by Dr. Joey Caputo, who's been seconded to our unit from the National Department of Health and who's been teaching me and many of us about the monitoring and response unit. So the question was, what was the problem that I identified when I became the DCST pediatrician for the Waterberg, and why was it important? And so the Waterberg district is a very vast geographic area. It's about a third of the Limpopo province. And the good news about it, from my point of view, it's quite sparsely populated. It has 7 district hospitals and 1 regional hospital. And there was a need to improve the clinical practice and to bring constructive teaching, to bring accountability, and to monitor and track morbidity and mortality trends in the district. That was a challenge to me as I started this job. The need to use, I also thought it was important to use the Child PIP program and the DHIS program as 2 complementary monitoring systems, and to see how we could use the 2 together. And the importance was to address the clinical risk in the district hospitals and the referral hospitals, and to ensure accurate mortality statistics, because it's a very vast area. So what did we do to address the problem? We introduced a compulsory 24-hour death reporting. And how does that happen? And the facility, the operation manager will report the death of all under 5 children. That doesn't include neonates. In this case, they get reported through the PIP system. And that goes to the district child health manager. She that will then let me know, or the DCST nurse know, but also the information officer in the district about the death. And then the district team will call the facility, the medical officer or the professional nurse, and discuss the case. That happens within 24 hours. But within that time, if possible, we'd like them to hold a critical, what we call a critical review, within 24 hours, a review meeting of all the stakeholders, including the primary healthcare people that were involved and the emergency people. And we'd like to ask them to keep the minutes in the format of the Child PIP Death Audit Report. That Child Death Audit Report then gets sent back to me, or to the professional, or to my pediatric nurse, and it's captured on our child PIP and program, and it is reviewed by me immediately. If I feel there's a big problem, and I've talked already to the doctor, I feel that I need to get to that hospital, I will go, but often I don't have to do that, and it can wait until the monthly child PIP mortality meeting at the facility, which we will always attend. It's always attended by the DCST team. We combine it usually with the perinatal meeting as well. And we like we always insist that the primary healthcare staff from the clinics around the hospitals also attend that. It also becomes a teaching and a discussion program. Then we have a monthly monitoring and response unit where we report this back to as well. And that is held at the district, but also in the sub-districts. And that leads into, and at those sub-districts, we like the CEOs at least, or rather the clinical managers at least, or sometimes the CEOs to attend those district meetings. The MRU meetings go to the district executive manager to keep them informed. We have monthly, quarterly, and annual child PIP reports to support the various other data. So the new practice for us was and all of that happened as a result of the obligatory 24-hour death reporting. So could the practice be scaled up beyond to where we brought it, and how? We think it's easy to implement. It's cost effective. It requires no extra staff or equipment. It requires cooperation, however, between the managers of the child health programs, information officers, and the DCST team. It requires dedicated attention to detail, and it does require fantastic, huge perseverance. You start feeling a bit like an undertaker sometimes when things go very badly. It requires an attitude of clinical integrity, non-judgmental and respectful inquiry. That's very, very important. And the progress, I think, can be easily demonstrated and mentored. So what happened? Firstly, for me, the medical officers have become aware of their accountability in these district hospitals, which are far away from me and far away from everyone else. And they understand now the need to follow protocol and best practice. I have become aware of each hospital's strong and weak points, and the Child Health CHIP program, PIP program, has been fully implemented now in all the district hospitals, and there can be an immediate response if there's an untoward event and an adverse event. Monthly mortality meetings are held in all the hospitals based on the death audits, and appropriate teaching is given. Monthly monitoring and response units are held, as I said, regularly. So this is just a dashboard. Thank you to Dr. Robertson who provided it to us, just to show on children with severe acute malnutrition. You'll see that those are the 5 districts in the Limpopo. Waterberg is second to the bottom there. We started with a case fatality rate of 17.4, and we've been able to bring it down to about 5 at the moment and 6.5 last year. And of course, it's not only because of death reporting, but partly. So this is some more indication of what we've done in the Limpopo, in the Waterberg. If you look at our case fatality rate for severe acute malnutrition, we've talked about. Interestingly there, while we're in that category, it's important to notice that our incidence of severe acute malnutrition is increasing. So it's been interesting to be part of this meeting, and I think we can take a lot of messages home. Diarrhea disease, I've put it as yellow because we've had occasional blipses, but we are able to follow that up, and pneumonia is also monitored closely. So the 24-hour death reporting has contributed to effective clinical management and monitoring of junior medical staff at the district hospitals, which are remote. There's close monitoring of clinical risk, and the identification of areas of clinical practice that need to be improved is easily found. Accurate mortality statistics are kept, and it can inform managers where they need to adjust and where they need to investigate, and it can be a useful tool for research. So is there anything we would have done differently? The difficult part really is logistical, as usual in the Limpopo and in the Waterberg, to try and get these people who are far apart together for a meeting within 24 hours is not always easy, but it has to be done, and we have to do the best we can. I would also like it if the information officers were more clinically trained and could understand what they're actually dealing with. Thank you very much.